say and what I mean by variety is you will be dealing with a wide range of patients, um, ranging from acute and relatively well patients to very ill, from from acute very ill patient to relatively well chronic patients. Also, those patients have different medical background, um, and also it involves some procedures like venous biopsy and central lines. And yeah, so the other question is who will enjoy renal medicine, and or we can say will be comfortable in renal medicine is those who are self-directed and independent doctors who doesn't usually need guidance, and they can make decisions very easily, and also those who need variety in their um, area of operation. Also those who are inquisitive or like to play the detective roles. The others, now I'll be talking about the training in the UK. Yesterday I think Islam touched a little bit about the training in the UK. So I'll skip this slide and I will show you a diagram here. It shows the natural pathway training, the physician training pathway in the UK. So after you finish medical school, you go into foundation training, which is which is equivalent to Sudanese internship, and then you will after that you apply for INT. This is called stage 1 training. It used to be 2 years, but now it's 3 years, INT 1, 2, and 3. The final year, you will be in the senior rota instead of junior rota. So you are a senior registrar, but you're not in a training in a specific specialty, I mean. And then you'll be eligible to apply for you will be eligible to apply for higher specialty training or stage 2 training, which is a 4 years of training in the
معليش ممكن أقاطعك يا رزان؟ هل في سلايدز ولا بس حتكوني بتتكلمي لأنه إحنا ما شايفين حاجة
أنا ما أقدر أصدق أنتوا قاعد تسمعوا فيني.
إحنا سامعينك لكن ما في سلايدز.
أنا بتكلم من قبل بعمل في تريننج، أنا ما لسه بحتكلم أول زول.
لا إحنا
I am really sorry. أنا خلاص طيب أشير يعني أبدأ أنا.
وإحنا كان مفروض إنه حنبدأ بالميديكال أونكولوجي.
أيوة أنا بعمل ريهرسل صاير مع روحي.
لا
ما قال المايك شغال، أنا متأسفة.
ما في مشكلة. أفتكر first speakers I will introduce them كان ريمان ويسرى, and they will be presenting about medical oncology.
أوكي، إذا عايزيني أبدأ من أول وجديد لأنه في مروة معي حتكمل السكورينج سيستم. إذا عايزين ننتظر الفيرست بريزنترز هم تو بريزنت وبعد ذاك نواصل أوكي، لكن أنا am really sorry ما انتبهت إنه المايك شغال والله.
مفروض يسرى تدخل عشان هي أفتكر حتبدأ نايت شيفت.
أيوة
عايزة تبدأ أول. أفتكر الفيرست speaker يسرا is having technical difficulties. فممكن يا رزان تبدي لنا من الأول share your slides ومعاكي مروة. You're going to have 15 minutes talk, is that right?
Yes.
Okay. Well, let's start from the beginning.
You mean أبدأ أنا؟
أي أبدأ بالميديسين لحد ما بعديكم الميديكال oncology لأنه I think they're having technical difficulties to join us.
Okay, just give me 1 minute أو 2 minutes بالكتير.
Okay.
Hello?
أيوة سامعنك.
Okay, I'll share my screen and just confirm if you can share it, if you can see it.
Yeah, you can see it.
Assalamu alaikum wa rahmatullah. Good evening, everyone. My name is Razan, and me and my colleague Marwa, we will be speaking today about renal medicine specialty training in the UK. I'll start by answering 2 questions. The first one is why renal medicine? And can you see the second slide? Yeah. So the first thing is it's a very good area for research. And the second thing is the variety that the specialty provide. And when I say variety, I mean, I'm sorry, can you see the slides?
Yeah, we can see it.
Yes, but it's not in the slideshow.
Sure.
I just put on the slideshow.
Just time.
Okay, so as I said, it's a very good area for research and the variety that the specialty provide. And when I say variety, I mean you will be dealing with a wide range of different patients, patients with chronic and relatively well patient to acute, very ill patients. And those patients will be having a different medical background. I mean, patients with rheumatological problems, patients with endocrine problems. And also you will have a chance to do some procedures like renal biopsy and central lines. And the other question is who will be enjoying or comfortable in this specialty? Usually doctors who are self-directed and independent, those will be comfortable in such specialty. They usually don't need guidance and they can make decisions very easily. Also doctors who need variety in their area of operation, and lastly, doctors who are inquisitive by nature or like to play detective roles. And I just put person specification just to remind myself to share with you the link in the chat box later about the person specifications in doctors who are applying for renal medicine. Okay, I'll be, the second slide is training or renal medicine training. I'll just skip to show you this diagram, which illustrates the physician training pathway in the UK. Yesterday, Islam has touched this area, and it just explained after you finish the medical school in the UK, you start working in the foundation program, which is equivalent to internship in Sudan. And then you start your IMT training, and this is called the stage 1 training, and it is a 3 years training in which you rotate in different specialties, and you have your own curriculum up, and after that you apply for higher specialty training. The higher specialty training, it usually differs from specialty to the other. In renal, it is 4 years, after which you will sit the specialty certificate exam, and then you will be a nephrologist. Here, I'll be speaking a little bit about some data from the previous.
Sorry, we can't see the new slide. We are still in why renal medicine one.
Okay, I don't know why, because maybe it's the network thing.
I can share from my end if you want, Razan.
Okay, you can try. I'll stop sharing and you can try.
Okay.
On your side. Okay. Are you sharing now?
Just give me a minute. Which slide you are in now? Is this one?
Yes.
Razan?
Yes, Marwa.
Right.
This is not the one I was talking about. Can you just move on?
Right, is this one?
The second one.
Is it?
This is the one I was explaining to you about the physician training pathway. So I think it's the following one. Yeah, so this slide is, I'll be just giving a small talk about statistics and data regarding renal medicine applications. So this table will show the proportions of the first preference interviewees applicants who will be invited to their first choice regional preference. And if there is only one thing I would like to talk to you about is that Scotland has the higher chances. I mean, 100% of doctors who apply to Scotland as their first region preference, they got an interview there. So if you don't mind going to Scotland, I think it would be a good idea to apply in Scotland. So the second slide is just showing you the distribution of shortlist scores awarded to all renal medicine applicants submitted in 2020. And I would use this data to have my own plan if to scoring myself. What I mean to say is the average scores that were achieved in order to get to be shortlisted is from 39 to from 38.5 to 39. So it would be a good idea if I am planning to apply for renal training, let's say next year. Let's say next year, I will do my best to get a 39 score just to increase my chances in getting in being shortlisted. The next slide is Marwa. Can you move to the next slide? The next one. Okay. So this chart. It shows the distribution of final assessment score. This is after the interviews. I don't know if we're going to have interviews in this year or not because of the COVID. But if we have interviews, this data will be helpful. It just describes the final assessment scores awarded to renal medicine candidate assessed using the revised scoring process in 2020 ST3 recruitment round 1. And as you can see, the average scores were 34 to 35. And that is to say, if I was shortlisted, I will be aiming to get from 34 to 35 score in my interview, just to increase my chances in getting a training in renal medicine. And I think that's it. I will leave the stage for my colleague Marwa to go with you through the application process and the scoring system. I just want to say it's very important to know the scoring system because it will help you to plan ahead. I mean, if I am going to apply next year, I would study the scoring system and see and to develop my own plan to get the average scores to have a chance in the training. And thank you all. If you have any questions, please just put it in the chat box and I will answer any of your questions. And thank you and have a lovely evening. Marwa.
Thanks, Razan. Good evening, everybody. My name is Marwa. I will continue the presentation regarding renal specialty application. So the application date it has already started from 15th of November till 9th of December. And submitting of a bill will start on 13th and continue until 20th of June. Sorry, January 20th.
The voice is not very clear.
How is it now?
Yeah, this is better. Just raise your voice a little bit.
All right. So I have said that the application has started already from 18th of November and continue till 9th of December. And you will require to submit your evidence from 13th to 20th of January. And the interview dates are 15th to 17th of March, due to be decided whether it would be face-to-face or virtual interview. So I'll not spend time on this because it has already been explained yesterday. The criteria you have to have your MBBS and your MRCB at least 1 and 2, language, health, and fitness to practice, and flying form or IMT training. So scoring and shortlisting, the specialty will be assessing your commitment to specialty as a part of shortlisting process. So you have to show your commitment to the specialty. At the time of application, the evidence are not required, so work on collecting them, but they are not required now. Try not to underscore yourself, so everything is small could count, and every single point could move you 100 degrees across closer to your appointability. So, regarding self-assessment, how would you prove yourself? You need background noise, if you mute the others. Regarding commitment to specialty, you will be scored from 0 to 10. How to prove yourself as committed to renal specialty? You need to show initiative to drive. If you have a work in renal unit, that would be good. If you are not working at the moment with renal unit, you can contact your local renal department and start working with them, or attend renal clinic if there is no department. But most of the hospital have renal clinic, so you can do that and collect evidence. Try to do some audits in renal medicine and attend some renal activities and courses like simulation courses, RCB teaching days, and e-learning and UCL renal courses. And tester weeks, this is available in some training programs, so you can ask for tester weeks in renal specialty. If you work as a renal registrar, this show a high degree of commitment to specialty. You should be aware about the curriculum and how to be acting as a renal physician. And undertaking activity outside of your normal work. Say that if you are working as a endocrinology junior doctor, so your duties are just based with endocrinology. If you did anything away from that, this shows that you have the initiatives, you have the ability to work outside of your usual commitment and work. The second thing in the self-assessment is the undergraduate achievement. If you have any degree of Bachelor of Science, for example, if you got a first class degree, this should be based in the UK system, and you have to prove that this is equal to UK grading system as a first class. Everything from 70 to 100% proves it's equal to UK first class. This is counted. You'll be required to justify why you select this. There is an overview tab that could help you how to score yourself against your achievement. Postgraduate like PhD, also as has been discussed earlier, be careful when you choose an option to justify why you have chosen this option and to prove the evidence. At this, don't include the MRCB or teaching, separately they will be scored. Achievements, any honor or distinction awarded, no more than the top 18% if you have that. that's good will be scored like 6. Price related to medicine. Instead of in terms of presentation, any oral presentation you provide, you have been invited to. The evidence for that is the invitation letter. If you have presented a poster, also that counted if you have the evidence by the invitation letter. But if you presented a poster by yourself and you didn't have invitation letter, this is not counted. And if you have arrangement for presentation or poster or anything else, and that has been cancelled due to COVID, if you have evidence to prove that the process wasn't going but stopped because of COVID, it also could count. Further on is the publication. So the higher score is for 2 or more PubMed cited original research publication. Anything could count, but not the full mark. As I said before, use overview tab to just show you how to choose the appropriate option for your achievement. Teaching experience and training on teaching. For teaching, you will be scored up to 6, and for training up to 4. To get 6 in teaching, you have to be delivering a teaching session regularly for 3 months, and you have a feedback from at least 5 audience. And for training, you have to get 4, you have to have at least 2 days of training. QIB, maybe a new project, or could be something ongoing, and then you join a trust and found the project is ongoing, and you became part of it, and you have completed 2 cycles at least. And to evidence what you have done, you need to provide a form, QIB assessment tool, or a headed letter from your department. It has all component of the QIB assessment tool. Leadership, you'll be scored 0, 3, or 6. It has to be at least for 6 months. Examples of this, like national executive for BMA or trainee representative. Examples of roles in non-medical voluntary capacities like charity, scouting, guides, sport, creative art, police or military work. You must be able to indicate how you have made a difference in your role, and the evidence has to be a headed document from the organization that you work with. State your role and the requirement of your role and your contribution, and a feedback from your colleague as well. So the previous session where slides were about the self-assessment and scoring. So the interview, I'll skip the application because most of it is about the self-scoring. The rest has been discussed earlier. So for the interview, important tips, try to make a good first impression, dress well, avoid IT issue, and prepare with solutions for any potential issues. Have punctuality, maintain good eye contact, talk slowly, keep a good eye contact with the whole panel, don't ignore one. Repeat question if needed. If the interviewer has said question not clear for you, ask them to repeat it for you. Approximately, it is about 30 minutes. It has 4 questions, each 5 to 8 minutes. You will be marked on this question, and the 5th question is a communication, which is not an actual question. So you will be assessing your communication skills throughout the interview. The interviewer will score you separately. They are 2 interviewers. So the first question is clinical scenario. It is relatively brief. You will be given the question beforehand. They will allow you time to just formulate the discussion and how you deal with the scenario. Be systematic, always follow ABCD approach, gather information if needed, and then come up with a plan. You will assess you about your communication skills and communicating your plan of management with your colleague, family. the scenario could involve remote consultation from district hospitals without renal department. They will assess your safety in remote consultation and how you will be supportive for your colleague who are not familiar with such cases. They will assess your awareness about safe transfer, for example, patient with severe metabolic acidosis, electrolyte imbalance. They will assess how you will approach this. Also assess your safety when to escalate to your seniors. So bear in mind all this when you approach the scenario. And also be aware about the latest guidelines for management of most common renal-related issues. The second question is about your suitability as a medical registrar. So basically, this is not a clinical aspect, it's just how you will deal or act as a medical registrar on call, solve all problems that happen overnight, and how you will deal with your colleague, how you distribute the jobs for your junior, how you will manage discharge planning from ED or from AMU, how you will communicate with family, how you take decision like end of life or DNA CBR, all this sort of stuff. The third question is an ethical scenario. So just test your knowledge about the good medical practice and ethical principles. Usually it starts with a dilemma with patient with multiple comorbidity. Maybe there is problem with his capacity, conflict with his best interest and next of kin wishes, and this sort of scenario, and how you will deal with this with such a situation. Suitability and commitment. This question will focus in your suitability for commitment and training. This will be like an extension for what you have submitted in your application. You will take you in depth for what you have submitted. Nothing more than what I have discussed earlier. So as I said about the communication, just try to be more fluent, clear in your communication skills. Now the interview has finished, and then it come to your score, and they will assess your appointability. Again, it's your scores that you have achieved. So first, let us talk about the raw interview score. So you have been assessed by 2 interviewers, and you have been assessed for 5 elements or 5 questions. So each interviewer will give you 5 score. The total is 10. The raw interview score is from 1 to 5 from each interviewer to each question. So you will be scored from 10 to 50. So the score you will get from this, it's called the raw interview score. So how you will be appointable, if you have met these 3 criteria, you will consider as appointable, and then you might get an offer for a job. So none of your 10 interview score can be 1. No more than 2 of your interview score can be 2. And your raw interview score has to be at least 30. If you fulfill these 3 criteria, now you will be considered as appointable, and you may get an offer for training post. This is the end of the renal specialty application. I'm not quite sure if the question time is now or later. Hello.
Yes, thank you. Thank you so much for your presentation. You can leave your questions in the chat box. We'll try to answer them later.
Okay.
Next, we will have Yusra and Nariman, and they'll be presenting about medical oncology. يسرا وناريمان موجودين معانا مش كده؟
Yes.
Do you want to start sharing your screen?
Yes. You can see my slide now.
Yeah, we do.
All right. Hi everyone, I'm Yusra Gadi, one of the senior clinical fellow in emergency medicine. We'll talk about medical oncology. So our introduction to nature of work and rule. So as a medical oncologist, most of us working in general medicine or other specialties, so we are not working in oncology. So maybe we face a patient with acute oncology complication or cancer complications or side effect of medication in our acute take or in ward. So just I will give brief of medical oncologist. So your aim is to provide either curative or palliative treatments and good quality of life for cancer patients, to provide counseling for patients and their family. You will be a part of clinical research, clinical trials, and clinical care and laboratory interpretations for all cancer patients. Work as a part of multidisciplinary teams, this including clinical oncologists, surgeons, interventional radiology, other departments, psychiatry. So your work will be diagnosing cancer, discussing treatments and treatment complications with the patient, with the family, and supporting patient and their life after treatment. So as we say, the complications, so you need to support your patient after starting treatment as well. So one of the common questions, medical oncology versus clinical oncology, what is the difference? We are talking about medical oncology, but in brief, clinical oncology covers both therapeutic administration of radiotherapy and chemotherapy. However, only the clinical oncologists administer radiotherapy. So as a medical oncologist, we are not—
Sorry, Dr. Yusra, your slides are not changing. We are still seeing the first one.
Really? Okay. You can see now? I don't know what's the problem.
No.
Not yet.
And now? Still? Hello?
هي أيوة كده اتغيرت، بس هعمليها سلايد شو عشان تتكبر.
Yusra, at the bottom left في slide share.
هو بيقول لي resume share, so I'm resuming share, but it will be like this if I resume share.
Did you try the bottom left?
Yes. So either
Down, left side. Yeah, this one.
so now you can see? No.
It's black now, we don't know.
Oh. How is it now?
No change.
I don't know what's the problem. You can see now? Hello?
Yeah.
We can, yeah.
I think it's better like this because
Yes, all right.
yeah. So this is our work rule and medical versus clinical oncology. So as a medical oncology, you will administer systemic medication like chemotherapy, endocrine therapy, hormonal therapy, and biological therapy, which is immune therapy. So for the training, as a medical oncology trainee, you need to complete an MRCP oncology exam during your training. And no subspecialty post training, but as a consultant, when you finish your fourth year of training, you can start working as one or two sites or area of interest, but no post training subspecialty. So the training pathway, it will be group 2 specialty. So we started from ST3, not ST4, and we're not including in dual training. So we're not including acute medical tech, it will be just oncology. So to apply for medical oncology, either you are completing IMT2 or 3, it's just it's recommended to complete 2, or CCT 3 years, so you apply as group 2. So starting from ST3 to ST6, 4 years, and this is not dual training. So when we are talking about the interview in medical oncology, so Dr. Maru already covered most of the interview content. The difference will be just in the clinical scenario and the suitability and commitment, so no big difference. So in clinical scenario, we'll talk later about this. Question 2 to be professionalism and governance. And this as a oncology registrar. So it will face like discussing angry patients, breaking bad news, your ability and suitability for the governance, clinical governance in your department. And so how dealing with your colleague, delaying colleague, all this in professionalism and governance. So academic, for clinical scenario, it will give you 25 points in interview. For professionalism and governance, will give you 12 points. For question and for academic research, this will give you 25. So you need to be aware of research. If you have a research, it will be good. So research and clinical trials. So you must be aware of how the research going and clinical trials, the 3 phases, phase 1, 2, and 3. Will be discussed in this question. It will give you 25 points. Suitability and commitment have account for 12 points. And this include if you work in oncology, or if you do anything related to oncology, like presentations, conference, attending clinic. So you need to show your suitability and commitment to specialty, and this account from 0 to 12. So the most point it will be in the clinical scenario and in academic and research. For scoring, as general, I'm not the suitable one to talk about scoring details, but 1 to 5 it will be poor. So you have 2 interviewers as a general. Your minimal raw interview score must be more than 24 to be appointable for a medical oncology. This will be added to your application score and total score from 100. So from RIS, you need more than 24 points as RIS to be appointable for post. So we'll go back to common complication in cancer patient. Just this because we have 25 points in clinical scenario. It will be either 2 clinical scenario or 1. And they tend to discuss either it will be in clinic or consultations from other departments like emergency department or inpatient. So the case, it will be mainly about like the most common cases or scenario complication of medications or common complication of cancer itself, like bone suppression, neutropenic sepsis, chemotherapy side effect, immunotherapy complications, cord compressions, superior vena cava syndrome, pericardial effusions, pleural effusion, PE, massive hemoptysis in lung cancer patient, or intestinal obstruction in colon cancer patient, piliary obstruction due to liver mets, urinary tract obstruction in prostate and urothelial cancer. So I don't know if I have time to talk in details about this, or we'll give a chance to my colleague Nariman to talk about her presentation. Hello?
Yes,
Hi.
with that.
So I have time to talk about this, or is enough for me? Hello?
You can go through them if you want.
Yeah. So if we talk about neutropenic sepsis, severe anemia and thrombocyte, this is all the operations. All this topic, just if you can go through it before interview to be ready for your interview. Spinal cord compression, we say thank you first to Nariman because he helped me in this topic class, complication. Thank you, Nariman. So spinal cord compressions, we just go through the spinal cord, this medical emergency treatment is being started with 1 hour, no delay and no days. So common with the prostate, breast, lung, lymphoma, and multiple myeloma patient. Clinical patients can come on with a pain, typically radiated radiculopathy pain and weakness. Sensory distributions, the main cornerstone of investigations for cord compression is MRI plus the clinical finding. We need to speed the management as to be less than 10% of patients establish paraplegia from metastatic disease, walk again. So we start dexamethasone 16 to 20 milligrams should be given immediately once we suspect cord compression. This can reduce peritoneal edema. Immediate surgical intervention if indicated, and radiation therapy to the spine. So if we talk about febrile neutropenia, it is the most common life-threatening, one of the most common presentation in ED. It's a complication of chemotherapy in cancer patients. Definition: a single oral temperature 38 or more, sustained over 1 hour with absolute neutropenia, less than 500 cells per microliter. So routine investigations, we must include blood culture, sputum, and urine culture as well. Just X-ray, we need to identify the source of infection. Treatment, we follow the micro guidelines. So I give empirical IV broad spectrum antibiotic, particularly if the patient is toxic or hemodynamically compromised. So there's antibiotic tazocine, gentamicin, amikacin according to your micro guide. So monitoring the patient and correction of hypoxia, hypotension, fluid imbalance, acid-base balance, renal function, and coagulopathy, etc. So fulminant sepsis require intensive supportive therapy with close monitoring. So I will not repeat it again. So immunotherapy, which is immunotherapy complications, can come with Guillain-Barré syndrome, myasthenia, encephalitis, uveitis, conjunctivitis, so affecting all the system, lung, heart, endocrine, gastrointestinal, kidney, rheumatological like vasculitis and arthritis, skin as well. Example for common immunotherapy in oncology is pembrolizumab and nivolumab and all these medications you can see. So I know I go fast, but if any Hello.
Yes, we can hear you.
Yeah. So I think I'm done with my presentation. So I give a chance for Nariman.
Okay, thank you. We'll
Yeah.
for Nariman. Dr. Nariman, can you start sharing? And yes, stop sharing, please. Yeah.
Assalamu alaikum.
Alaikum assalam wa rahmah. Yes, we can hear you.
Yeah, so I will start now with breast cancer, and let me to make a slideshow. Yeah, is it visible? Everyone can see my slides?
Now,
Yes. So I will talk about breast cancer.
No, we can't, not yet.
Okay, good. Okay. Breast cancer is the most prevalent and common cancer in women over the world.
Sorry,
Breast,
Dr. Newman, we can't see your slides.
you
We
cannot.
can't.
Uh,
Yeah.
I don't know what is the problem. Is it visible now? Is it clear?
Yes, we can see it now.
Okay,
Thank you.
so breast cancer is the most prevalent and common cancer in women over the world. Breast cancer is the second cause of cancer death after lung cancer. Usually it's common to affect the left breast, and usually it involves the upper outer quadrant in 50% of the cases. What are the risk factors for breast cancer? There is genetic predisposition, and this include BRCA1 and BRCA2 mutation. This is, I think, the most common mutations that can be found in patients with breast cancer. Then others like lymphoma syndrome, and in this syndrome there is p53 tumor suppression gene mutation. Other genes mutations include BTN, SHEC2, RAD51, BAB2. So there is a lot of genes mutations that can cause breast cancer. Other causes or other risk factors include nulliparty and use of oral contraceptive pills, late first full-term pregnancy after the age of 30, and no lactation, I mean no breastfeeding, early menarche before the age of 12 years, and late menopause after the age of 55, hormonal replacement therapy following menopause, and the age itself, as we know that 75% of all cases of the breast cancer are postmenopausal. The risk, other risk factors, benign breast disease, and this include like hyperplasia with atypia, papillomas, sclerosing adenosis, and lobular carcinoma in situ. Physical inactivity, exposure to ionizing radiation, like if there is a patient had a history of lymphoma when she was a child and she received radiotherapy to her chest wall, then this is considered as a risk factor. So this patient has a chance to get breast cancer in the future. Alcohol consumption, high dietary fat intake, and obesity. How we will diagnose and investigate breast cancer? The first one is a physical examination, and when we will say a physical examination, we need to examine the breast, looking for a lump, and then after that, if I suspect that there is a breast cancer, then I need to do ultrasound. and ultrasound will help me regarding biopsy or sometimes fine needle aspiration. It can be taken if there is no possibility for breast biopsy, but the breast biopsy is mandatory. And then we have the mammogram, and a mammogram will give us a diagnosis that there is a lump with a high suspicion of malignancy like BRAT4 or BRAT5. Then MRI breast is indicated if we are in a dilemma, is this lump is a malignant or benign, then we can do MRI breast, and it will help us regarding the final diagnosis. And also MRI breast will be needed if the patient will need chemotherapy before surgery. Then after chemotherapy, we will do MRI breast looking for the lump. If the lump is getting smaller, then the patient can be a candidate for just breast conservative surgery, which is just tumor removal. Or if even after the chemotherapy still the lump is large, then the patient will go for mastectomy. Others investigation will include complete blood count. It will help us, like if there is any pictures of pancytopenias, and this will give us clue that maybe this lady, she has a bone marrow metastasis. Liver functions, if are abnormal, then this also maybe this lady, she has liver metastasis. Alkaline phosphatase and serum calcium also may be high or abnormal if there is a bone metastasis. Chest radiograph to looking for any metastatic lesion in the chest. As we said regarding the physical examination, just remember this 24 lemons shape. If you notice any changes in the breast similar to any one of these lemon changes, just keep in your mind, maybe this patient really had a breast cancer. Okay, and there is like this lady, she has obvious mass with the skin changes blood orange, so this is breast cancer. And like this lady, she has a lump, but it's not obvious, but there is a skin retraction, also this is a sign of breast cancer. And this patient, she has nipples, eczematous lesion in her nipples, and this is the characteristic of Paget's disease, which is one of the type of the breast cancer that involving only the nipples. Then this lady, she has a different type of breast cancer, characterized just like, it looks like mastitis, redness of the skin, and this is called inflammatory breast cancer. It's one of the breast cancer with poor prognosis. Also this one, she has inflammatory breast cancer. Others investigations that needed included CT scan, chest, abdomen, and pelvis with bone scan. Usually, it's not indicated for any patient with breast cancer, but if you think that the tumor size is more than 5 centimeters, or the patient on examination or by ultrasound, she has axillary lymph node that confirmed by biopsy there is metastasis in this axillary lymph node, then the ideal to do chest, abdomen, and pelvis CT scan plus bone scan to rule out there is no any metastasis. Or if the routine blood test show there is any pictures of any abnormality, like abnormal liver function test, then I will recommend to do CT scan looking for any liver metastasis. Bone marrow aspiration is needed also in certain cases, like if the patient, she has unexplained cytopenia, then I need to put in my mind maybe she has bone marrow infiltration. When the breast biomarkers, I think there is a many biomarkers for the breast, and but the most common, I think it's the phase 3 one. It's the ER, which is estrogen receptor, and PR is the progesterone receptors, and HER2, which is the human epidermal growth factor receptors. These receptors will be checked in the tumor itself in the biopsies that taken from the breast, and if the patient has any positivity of this one, then we, like if she has ER, then we say okay, this lady, she has ER positive breast cancer. Usually ER and POR and B and PR positive breast cancer, they have a good prognosis. HER2 positive, they are we can say like a poor prognosis if the lady she has a HER2 positive. And also the biomarkers will help us regarding the plan of the treatment. If the patient has ER/PR positive, means her hormonal receptors are positive, means the cancer cells will be affected by estrogen. So we need to give anti-estrogen therapy for this lady, what we call it as endocrine therapy. And if the patient she has HER2 positive, then she is a candidate to receive anti-HER2 medications, which are trastuzumab and pertuzumab. The other biomarkers will help us if the patient in metastatic disease, then we will request like PD-L1 or MSI test, and this is are indicated if we think that we need to give a treatment like a targeted therapy because there is too much update in the management or in the treatment of the breast cancer. So there is a certain medication against each biomarker, like anti-PD-L1, okay, and anti-MSI medication. So all these medications will help us for the treatment of metastatic breast cancer. The histological classification of the breast cancer, I think most of the people know that the most common one is the ductal adenocarcinoma, and the ductal adenocarcinoma accounts 70 to 80% of the breast cancer. And we have non-invasive breast cancer, like ductal carcinoma in situ or lobular carcinoma in situ. We have also lobular carcinoma, which account 10 to 15% of the breast cancer. Other types of breast cancers are not common, but we go just fast through it, like inflammatory breast cancer, as we saw it in that previous image, Baggett's disease of the breast, and cystosarcoma phylloids, and other rare tumors, including squamous cell carcinoma of the breast, lymphoma of the breast, and sarcoma of the breast. Just I have a comment when we will say ductal adenocarcinoma. This is the breast, and we have, this is the lobules, and this is the duct, which is the milk duct. If the tumor arises from the lobules, then we say this is a lobular carcinoma. And if the tumor arises from the milk duct, then we say this is a ductal carcinoma. And if the cancer cells just inside the duct itself without invading the basement membrane, then we will say this is ductal carcinoma in situ, which is a very early stage of the breast cancer. The same for lobules. If the cancer cells just inside the lobules and doesn't invade the basement membrane, then this is called lobular carcinoma in situ. And lobular carcinoma in situ, it's considered as a pre-malignant condition despite of the presence of the cancer. But there is a two option, either to go for surgery directly or to keep the patient just under regular follow-up. Okay, and they have a risk to develop breast cancer over 15 years. If the tumor invade the basement membrane, I mean the cancer cells invade the basement membrane and went and grow beyond the basement membrane, then this is the invasive ductal carcinoma. And the same for the lobules. If the cancer cell extend beyond the loops, then we will say this is invasive lobular carcinoma. It's the same, like just the same prescription for invasive and non-invasive breast cancer. This is the molecular classification. I think it's just we can go very fast. We have luminal A. Just remember, luminal A breast cancer. This is the best type of the breast cancer with very good prognosis. And usually, luminal A means the cancer cells have the ER receptors are positive, and progesterone receptors also are positive. And they are usually, this type of the tumor has a less response to the chemotherapy, but at the same time the prognosis is excellent with this type of cancer. We have luminal P also, they have estrogen receptors, but their prognosis is less than luminal A. We have also HER2. enriched tumors, and this means that the cancer cells has HER2 receptors in her cells, and the patients will be a candidate for anti-HER2 medication like trastuzumab and pertuzumab. Then we have triple negative breast cancer, and when we will say triple negative means the estrogen receptors are negative, progesterone receptors are negative, and HER2 receptors also are negative. And triple negative is have a poor prognosis. Although this type of the cancer cell, they have a good response to the chemotherapy, but unfortunately they have a poor prognosis. Other type, collagen low, normal like breast cancer tumor. Breast cancer staging, as we remember, we have non-invasive, as we said, and the non-invasive is a very, very early stage of the breast cancer. We have invasive breast cancer, and we have metastatic breast cancer. The invasive breast cancer, the stage of the breast cancer, it depends on the tumor size and if there is any lymph node involvement or no, and the number of the lymph node involvement. Like here, we can say this is stage 1, the tumor is just, it's early disease, the tumor is just confined to the breast and there is no lymph node involvement. Then stage 2, it's also still early stage. The tumor just involved the breast and the axillary lymph node with metastasis to the axillary lymph node. Stage 3, usually it's a locally advanced disease. And when we will say locally advanced disease means there is invasion of the tumor to the chest wall, okay, and involvement of the epidolateral internal mammary lymph nodes. And unfortunately, this is stage 4, which is the metastasis to the brain or to the liver or the lung or bones, as we saw here. The treatment of the breast cancer, it depends on the stage, if it's early stage of the breast cancer or locally advanced or inoperable breast cancer. And inoperable means the presence of infiltration of the skin or the chest wall or fixed axillary lymph nodes involvement N2, N2, N3. Metastatic breast cancer, it's treatable, but unfortunately it's not curable. The aim of the treatment, will started by neoadjuvant chemotherapy, and there is certain indications for neoadjuvant chemotherapy. And when we will say neoadjuvant chemotherapy, mean the chemotherapy will be given before surgery, and there is certain criteria for this indication, like if the tumor is large and I need to give chemotherapy to reduce the size of the tumor, which is called cytoreductive chemotherapy, for a lady who desire to do breast conservative surgery rather than to do mastectomy. If the tumor size is more than 5 or equal 5 centimeters, then I will give neoadjuvant chemotherapy. And if there is axillary lymph node involvement, then also I will go with neoadjuvant chemotherapy. Okay, if the tumor is locally inoperable or advanced at presentation, then we will give preoperative chemotherapy with anthracycline and taxane-based chemotherapy. If the patient has HER2 positive, then also I will give anti-HER2. This includes trastuzumab and pertuzumab. Early stage breast cancer, of course, is curative, and then after the chemotherapy, we'll go for the surgery. And some patient will go also from the beginning. Directly, they will go for surgery without any neoadjuvant chemotherapy. The surgery, usually, we have 2 types of surgery, either to do modified radical mastectomy or to do breast conservative surgery, means just white local excision of the tumor. And at the same time, they will do surgery to the axilla, and this will depend on the axillary lymph node involved by breast cancer, or they will do like sentinel lymph node biopsy. And sentinel lymph node biopsy, this is the first step that will be done. It's just when the surgeon will do the surgery, they will inject dye at the site of the tumor, and the dye directly will go to the first lymph node that involve it, and they will take a biopsy from that lymph. They will remove this lymph node, and they will and at the same time the pathologist will go through this lymph node. If it's positive, then the surgeon will go deeper and will do axillary lymph node dissection. If it's negative, then just he will stop and he will not go further for axillary lymph node dissection. Then after that, some patient will go direct, as we said, for surgery, and some of them will go with neoadjuvant chemotherapy. If the patient went directly from the beginning to the surgery, then we have an option to give a chemotherapy after the surgery, which is called adjuvant chemotherapy. And the indication for this chemotherapy, usually if after surgery, they discovered that this lady, her axillary lymph node are involved by the breast cancer, or the patient has a high risk like hormonal negative, which is ER/PR negative patients. The tumor was high grade or poorly differentiated. The patient has HER2 positive, or they will do what we call it oncotype DX or mama print analysis to this tumor. And if it shows that there is a high risk of recurrence, then this patient will receive adjuvant chemotherapy after surgery. We have adjuvant endocrine therapy also, and it's used for the patient who have ER and PR positive. Usually they will receive this treatment for 5 to 10 years. We have two options, either the selective estrogen receptor modifier, and I think all of us, we know tamoxifen, and it will be given for 5 to 10 years. If the patient has a high risk of recurrence, then I would recommend to continue for 10 years. If the patient has less risk of disease recurrence, then 5 years of treatment is enough. Aromatase inhibitors, usually it's preferable for postmenopausal women, either letrozole or anastrozole or exemestane. Type of chemotherapy usually will give like 6 to 8 cycles of chemotherapy. The duration of chemotherapy between 4 to 6 months of anthracycline-based chemotherapy. And when we say anthracycline, means ibrobicin, doxorubicin chemotherapy, and taxanes-based chemotherapy, taxanes like paclitaxel, docetaxel chemotherapy. Other type of chemotherapy that can be used like venereal pain, carboplatin, cisplatin, but these types of chemotherapy usually will be preferred in metastatic disease. But doxorubicin, ibrobicin, cyclophosphamide, paclitaxel, docetaxel, these are indicated in the neoadjuvant or adjuvant setting. Prognosis of breast cancer, be very optimistic, as there is marked improvement in overall survival and disease-free survival in patients with breast cancer. Metastatic breast cancer patient can survive for several years with good performance status. I finish, and thank you.
شكرا. إذا في أي أسئلة ممكن في الشات بوكس. أفتكر آسيا حتقدم لنا a case presentation، وبعد ذاك ممكن نجاوب على كل الأسئلة.
I'll be presenting Infectious in a bit, I think, maybe after Asia.
Okay. Okay, can I screen share my? Okay.
Yes, please.
Sorry, 1 minute. I don't know what is going on. Minute. I don't know why I can't. Can anyone see my screen or no? Not yet.
No, not yet.
Hello.
Yes.
I'm struggling with sharing my screen. 1 minute. Okay, I'm going to share. Okay.
Yes, it has started sharing now. Yes, we can see it.
Shared already. You can see it.
لا
Yes, we
شايفين
can see your
واتساب.
WhatsApp.
showing the WhatsApp, but it should be in the. Okay. I should not share from here.
Are you using phone?
No, no, not again.
Good.
I'm using the computer. Can I send it to you, Marwa? Can share from you?
Yeah, send it. I'll share it for you.
Okay. Okay, I send it to the WhatsApp.
Good. Just give me seconds.
Okay.
Here you are.
Yeah, thank you very much.
You're welcome.
Can you give me the control of, okay, thank you. So, Assalamu alaikum. My name is Atia Al-Hassan. I'm gonna present quickly a rare disease, which is primary renal cell lymphoma, which is a rare disease, and it's the first time for me actually to see a patient with a primary renal lymphoma. So I'm gonna go quickly through the case, then I will move to the case discussion. Okay. Can you hear me well?
Yeah, we do.
Yes, yeah, we can hear you.
Yeah, so it was a 75-year-old male who was normally active and independent. He was referred by his GP because he was feeling unwell, not quite himself, with nausea, but no vomiting. He has right leg pain. So the patient was seen first in ACU in March because the GP referred him because he has intermittent leg pain and was treated as suspected UTI. He has no significant history. I can't move the screen, I don't know. Marwa. Okay. So when this patient admitted, he was alert, conscious, and communicating. GCS was 15. His observation was fine. Systemic examination was unremarkable. Just the right side muscle was wasted with increased sensation. His investigation was fine, only his DGFR was 39, which was normal 4 months before his admission. He has a family history of renal cell carcinoma. His mother died of renal cell carcinoma. So in light of this family history of cancer, we requested a CT TAP. This is his CT TAP, come back as showing a renal lesion. Okay. So the CT TAP reported a report come back showing abnormal appearance of both kidneys with diffuse area of low attenuation appearance, which could represent an infection or pyelonephritis, with more focal area, which he might be suspecting focal abscess, and they said just neoplastic lesions such as renal lymphoma remain within differential, but seems less likely. So when the CT result was explained to the patient, at that moment, he just mentioned that he has been suffering from right lion pain, which radiating to the groin, and pins and needles in his right leg. So in light of the CD finding, the patient was diagnosed as query pyelonephritis and started on IV antibiotic and referred to urology for further advice. The thing is that this patient has already CT renal in March 2021, which was normal, okay? So the patient seen by the urology team and advised to continue on antibiotic and monitor the response, and he might have cystoscopy in 3 weeks. So since the patient complained of back pain, so MRI spine was requested, and the report come back showing multiple metastatic lesion within the vertebral column with compressing the right L2 and L5, and primary could be from the kidney. So it really was a very shocking result because the patient was quite active and independent, and he's not having much of complaints. So we sent the myeloma screening, and the hematology team reviewed the patient, and their impression was this could be a query renal lymphoma. So they advised for renal biopsy and PET scan. So we discuss with the radiology for MRI findings, this could be RCC or no. So the patient also seen by the oncology, and they agree with the current plan between the medicine and the hematology. I mean the renal opinion. And we did the CT thorax to exclude lung primary because we are still thinking that should be from lung, not from the kidneys. So, and we also asked the radiology to review the images for advice ahead of renal biopsy. And they reasonably to be also reviewed in uro-oncology MDT. So during his admission, his renal profile continued to deteriorate, and his EGFR dropped to 17, and creatinine went up to 390. But the patient was clinically well and stable. Is just complaining of back pain and right side pain, feeling tired and less energetic. So the renal team advised to check a lot of things like urinary PCR and urinary ACR and urine dipstick for proteinuria, and we still continue on the treatment for Brisson pyelonephritis. So the CT was reviewed in the radiology, and report mentioned bilateral renal infiltrate pathology was filling defect going to the right renal vein and protruding into the inferior vena cava, and this is most probably a tumor thrombus, and the appearance is likely of renal lymphoma. So patient results discussed in urology MDT, and patient has renal tumor spread up with major vessels as well as spine. And patient is candidate of an IVC filter to prevent clots and renal biopsy. So we refer the patient to the other hospital RLI for IVC filter and renal biopsy, which is showed later on follicular lymphoma. Disease phenotype is aggressive DLB cell lymphoma. Primary renal lymphoma is really a rare disease which compromises less than 1% of extranodal lymphoma. Incidence is very low. It is defined as lymphoma involving the kidneys without prior lymphatic disease beyond the kidney. Majority are non-Hodgkin lymphoma, large B cell types. It is a disease of young male, and the male to female ratio is 1.6 to 6. The published medical literature regarding the natural history and clinical outcome of primary renal lymphoma remain very limited. The precise cause is unknown, but there is two suggestions. The first one is that it originates from the renal capsules and infiltrate the renal parenchyma. And the second explanation is that chronic inflammatory condition of the kidney attracts the infiltration of the lymphoid cells and eventually evolve into lymphoma. Because we all know that the kidneys are not containing any lymph nodes. That's why they are trying to find how the lymphoma develop in the kidneys. So primary renal lymphoma is usually unilateral, but it can be bilateral. And most commonly, it affects the immunocompromised patient, okay? The clinical manifestation is usually, there is no clear clinical manifestations. It's usually similar to renal cell carcinoma or renal abscess or any other kidney tumor, which make it difficult to be diagnosed. Gross hematuria, acute or chronic kidney failure, sorry. Flank pain is the most common symptoms, weight loss, palpable mass, and fever in young patients less than 18 years. Sorry. The diagnosis is usually suspected by the presence of renal mass, and it should be no evidence of extranodal lymphomatous involvement in the visceral organ or lymph nodes at first presentation to make it a primary lymphoma. Absence of leukemic blood pictures, difficult to diagnose by imaging alone due to its non-specific manifestation. So the kidney biopsy remains the gold standard test for the diagnosis. The management is chemotherapy, which is the most common treatment for primary renal lymphoma. The role of surgery is controversial. The use of radiation is also poorly studied. Prognosis remain largely unknown, and the
Asia, sorry, 4 minutes left, please.
1 year mortality can be as high as 75%. Okay. Median survival time is only 8 months to 3 years, and 5-year survival rate is only 40 to 50%. Younger patients and bilateral disease are associated with a poor prognosis. Thank you very much.
Thank you, Asia.
Thank you. I think we will go swiftly to infectious disease by Dr. Marwa. And if there are any questions, as usual, leave them in the chat box.
Okay, thank you. This is me again, Marwa Moon. I'm going to present regarding infectious disease, but particularly antibiotic stewardship. I will go briefly through the application and interview. So the dates, as stated before, the submitting of evidence is differ. It from 12th January to 1st of February, and interview dates 30 and 31st of March 2022. So the application is the same. So the infectious disease, there is two application. Group 1 for infectious disease, group 2 infectious disease combined with microbiology or microvirology, or virology. The requirement, the same MBBS, health and fitness of practice, and completing IMT training or alternative certificate for group 1 if you're applying for infectious disease, or group 2 for combined infectious disease. Commitment, as I said, for renal, you need to show your commitment to this specialty, having some experience, do some jobs related to the infectious disease, audits, presentation, and posters. The interview is differ a little bit from other specialty. So prepare, as I say, tips for presentation. Sorry, for the interview. The eye contact, the punctuality, the communication. So all apply here. You will be asked 5 questions if you are applying for group 1, and 4 questions if you are applying for group 2. The 5th question is medical registrar suitability for those who are applying for group 1. The first question is presentation. You will need to give a presentation on the following topics. Interesting recent development, research finding relevant to infection specialty. It has to be clear and relevant to specialty, and it is 3 minutes only, and no, it's allowed. So just you and the panel, and you can just take notes, a small note, just to keep the track. The second question is about the suitability and commitment. So just an extension for what you have submitted in your application. The clinical scenario is related to infectious disease. The same apply here. Prepare, be systematic, be clear in your communication, make appropriate plan and communicate your plan with your patient, colleague, patient relative, and so far. Quality improvement, this is not an actual question about your quality improvement projects. It's just about how far you know about the quality improvement project and how to implement one. So have your study about that. Medical registrar suitability, the same apply here. How you deal with the on-call and how you act as a medical registrar. The appointability for group one, so to be appointable, you have to have these three criteria. None of your 10 interview score can be one, no more than 2 can be 2, and you have to score at least 30 as your interview score. This is for group one. We set 10 because you will be asked 5 questions by 2 interviewers, so you will get 10 score. For group 2, 4 questions, 2 interviewer, 8 score. The criteria to be appointable, none of them has to be 1, and no more than 2 has to be 2, and the raw interview score at least 24. So come to my main presentation, the antibiotic stewardship. This is my objective for this presentation. I will go through the definition, goal, adverse effect of antimicrobial use, the principle of using antimicrobial and how to establish a stewardship program, the microbiology relationship with the stewardship program, and the evaluation of the program. In terms of definition, stewardship program is a systemic measurement and coordinated intervention designed to promote the optimal use of antimicrobial agents, including their choice, dosing, route, and duration of administration. This applies not only to antimicrobial agent, but antifungal, antiviral, and antiretroviral as well. The main goals of the stewardship program is to optimize clinical outcome while minimizing unintended consequences of antimicrobial use. Additional benefits include improving susceptibility rate to targeted antimicrobials and optimizing source utilization. So we're trying to avoid this antibiotic or antimicrobial side effects, which are mainly the emergence of antimicrobial resistance, selection of pathogenic organisms like C. diff, and drug toxicity, and has been stated that there is, in one study, 35,000 deaths are related to resistant antimicroorganisms. So when you use antimicrobial, you have to apply this principle. Initiating empiric therapy, this will help to improve the outcome, tailoring antimicrobial therapy to the targeted organism, converting to oral once it's suitable, and use the shortest effective duration, and to monitor the pharmacokinetic of antimicrobial agents. So in details for this principle, choose the optimal microbial agent after obtaining culture. And if the case is severe and taking culture takes time, so it's a priority to start the antimicrobial agent. The likely pathogen and their anatomic source. So bearing in consideration the penetration of the antimicrobial agent that you are using to reach that site, and site control or source control, like if there is abscess, so the surgery role, if there is pus about, let it out. It doesn't make any point if there is pus and you give an antimicrobial agent. So source control is crucial. The likelihood of drug resistance, like patient who is colonized with resistant organisms, or he has been using recent antimicrobial agent, or has exposure to health facility or local resistant pattern, according to hospital antibiogram. Host factors that preclude the use of antibiotic or antimicrobial agent, like people has allergy to certain antimicrobial agent, risk of toxicity with liver or renal derangement, and then taking consideration determining the appropriate dosing and route of administration, and initiate antimicrobial as promptly as possible. It has been stated in sepsis campaigns that delaying antimicrobial agent or antibiotic in sepsis by 1 hour increase the fatality rate by 70%. So starting antibiotic is promptly, and it is crucial. Then you need to tailor your antimicrobial therapy to target it, or we call it antimicrobial timeout. So the regime should be reevaluated continuously as the clinical status evolves. Adjust it to empiric from empiric to definitive once you got the culture results and sensitivity result. The spectrum can be adjusted also depending on the culture. It can be narrowed or could be broadened. The dose need adjustment as necessary. If there is drug level, we can guide with that. If there is renal derangement, we can take the GFR as a guidance to adjust the dose as well. If the clinical status is not the result of a bacterial infection, so we need to stop altogether the antibiotic or antimicrobial agent. The duration and indication has to be recorded correctly in the patient medical record. And then consider tailoring or converting to oral route. This intervention decrease the cost, facilitate discharge, and reduce complication related to IV access. And as much as you can use the shortest effective duration of therapy, the use of procalcitonin can be very useful in making a decision about stopping antibiotic therapy. The most important, the pharmacokinetic of medication. So it has been told that the medication are remedy or toxin. So if it's not used in the right way, it could be a toxin. So monitoring pharmacokinetic is very crucial, especially with vancomycin and aminoglycoside. Monitoring increase the likelihood of obtaining serum concentration within therapeutic range and reduce cost. Pharmacokinetic monitoring lead to reduction in nephrotoxicity, length of stay, and mortality. Why I can change? Okay, sorry. So now come to how to establish a stewardship program. So in initiating a program, it is important to focus effort and when possible to avoid implementing multiple interventions at the same time. So take it step by step. The core element for the stewardship program are leadership commitment. The leadership should be identified. Pharmacy is a very crucial member of the stewardship program. An action or one or more of the actions should be implemented by the program. So including prospective audit and feedback and pre-authorization and facility-specific guidelines for common infection. I will come to this in details in a bit. Tracking, monitoring antimicrobial use and resistant pattern in your institution. Reporting information of on antimicrobial use and resistance regularly to hospital personnel and leadership, and educate the patient and clinician on resistance of antimicrobial and optimal use of antimicrobial agent as well. So this are the main two programs of stewardship. In prospective audit and feedback, a trained staff, typically a stewardship pharmacist or infectious disease physician, review antimicrobial orders and provide verbal or written recommendation to prescribers regarding the optimization of antimicrobial use. So he just follow and observe and just write notes, or he could tell it in verbal form. But the prescriber has all the autonomy to follow that recommendation or not to follow. The other program is pre-authorization. So approval is required by infectious disease physician or pharmacist. This is especially for certain medication that has higher broad spectrum cover. So this approach provides an opportunity to optimize the initial choice of antimicrobial therapy, as well as an opportunity to educate individual prescriber about appropriate antimicrobial use, which may affect subsequent use. So if there is no monitoring of the antimicrobial use, so there's tendency of physician to prescribe broad spectrum just to treat their patient as quickly as possible. So when there is such a program, so every clinician will take time to consider what exactly they are treating and prescribe what exactly works in this organism, instead of just prescribe broad spectrum antibiotic or antimicrobial agent.
Sorry to interrupt, Marwa. Can you sum up in 3 minutes, please?
I'll do my best. So I will skip the advantage and disadvantage of these two programs. the interventions that needed to be implemented as facility-specific clinical protocols, antimicrobial stewardship program should develop facility-specific clinical practice guidelines and pathways for common infections based on local epidemiology, susceptibility pattern, and drug availability or preference, and setting standards for optimal antibiotic use for common indication at an institution. Implementation of inpatient pathways has been associated with more appropriate antimicrobial use and reduced length of stay. Electronic decision support is crucial to record the progress of the program. Point of care intervention by pharmacists. So pharmacists has the access to adjust medication or change medication or convert medication to oral, and transition from oral from IV to oral can be the program can develop protocols defining the appropriate patient for this intervention, and pharmacists can do this. Prescribe lead review of antimicrobial. So especially with the electronic system, when you prescribe, it would ask you, and it will not let you to prescribe unless you define the review date and stopping date for antimicrobial agent. Antimicrobial allergy assessment. So there is a lot of people allergic to certain medication, especially penicillin. And it has been studied that more than 90%, when they re-studied for their actual allergy to penicillin, 90% of them has been delabeled as allergic patient. So the allergy issue, it causes a struggle when you choose antibiotic to treat certain infection, and leads a physician to use a very broad spectrum antibiotic. So if we manage to actually define the allergy and the severity of allergy, this will help with choosing appropriate antibiotic. Educating prescribers. So is important intervention. It has to be the multi-group and integrated antimicrobial stewardship program. Education is the core curriculum and training program. And engaging staff. The presence of engaged infectious disease physician is critical. And in one study found that total antibiotic exposure and use of broad spectrum antibiotic were lower at sites where infectious disease specialists were present compared to sites without. And reducing the incidence of C. diff infection, this most important infection, with the collaboration of infection control program. So almost all antimicrobial have been associated with C. diff development. So in the general rule, reduction of antimicrobial use is likely optimal approach. So I'm going to talk about the relationship between the program and the microbiology laboratory. So it is an integral role in promoting appropriate antimicrobial, the microbiology laboratory. So the microbiology laboratory comply to antibiogram information at interval, usually annually, and make decisions regarding implementation of rapid diagnostic tests in addition to ongoing communication with clinician and infection control practitioners. The antibiogram is summary of antimicrobial susceptibility data for bacterial isolate recovered by microbiology laboratory over a defined period of time, usually annually. Antibiograms may be used by clinicians to guide choice of empiric antimicrobial therapy, and by stewardship program to develop facility-specific clinical protocols and monitor. For example, it will study that most of the isolate from urine culture are E. coli, and they are sensitive to, say, ciprofloxacin in this institution. So when you treat empirically for UTI before you get the culture, when you use the antibiogram, it will guide you and help you how to choose your empiric antimicrobial therapy. The data are most useful when stratified by if the samples were from inpatient patient or from outpatient source, and hospital side, is it the ITU, is it the medical ward, is it the surgical ward, and population, is it the surgical patient, medical patient, pediatric, geriatric, and so forth. A further iteration of combination of antibiogram is a weighted incidence syndromic combination antibiogram, which take into account body site from which an organism was recovered. Is it from blood? Is it from lung? Is it from urine? Is it from acetic tap, pleural tap, and so forth? The use of non-culture based diagnostic tools. The stewardship has to help by providing these tools as traditional microbiology takes time until we get the appropriate or start appropriate therapy. So the broad consulting immunological marker and point of care tests are very helpful in initiating antimicrobial therapy early on. So how we evaluate a stewardship program? So the optimal metric of monitoring a stewardship program are uncertain. So traditionally they were using the cost saving, focusing on process and outcome measures, maybe better illustrated program value and sustainability. Sorry for that. So stewardship program must select their benchmarking source like the baseline institutional data prior to implementation of the stewardship program, or data from a comparative institution, like you planning to start a program in 350 bed hospital. You can compare with this same capacity hospital nearby, serving almost the same geographic population. So this are the measures and outcome. So they measure the excess days of therapy, duration of therapy, proportion of patient compliant with facility-based guidelines, proportion of patient with revision of antibiotic, proportion of patient converted to oral, and the outcomes is the hospital length of stay, 30-day mortality, unplanned hospital readmission, proportion of patient diagnosed with hospital-acquired C. diff or other adverse event related to antibiotic, or proportion of patient with clinical failure. This is my last slide. I will just summarize what I have said. So the stewardship is a coordinated intervention designed to promote the optimal use of antimicrobial agent, and it is goal to optimize clinical outcome and minimize unintended consequence. Why we need stewardship? To avoid the side effect of antimicrobial agents like resistance and C. diff and toxicity. To avoid that, we need to use a rationale and principle when prescribe antibiotic. One important point in establishing a program is to take it one by one and establish one step, then move to the other. And the relationship between the biogram and microbiology laboratory is the antibiogram, which is very helpful in initiating facility-specific clinical protocols, which is most important intervention in the stewardship program. That's it. Any question?
Thank you, Dr. Marwa. I think for the sake of time, we will go swiftly to the next presentation.
All right.
The speaker is ready.
Okay.
Dr. Azza will be presenting histopathology and the talk about allergy medicine will be on tomorrow's taster day.
Can you guys hear me?
Yes, we can hear you.
To be a histopathologist, what do we do? And also we'll go briefly over the training program here in the UK. Can you guys?
Yes, we can see clearly.
Okay, yeah, perfect. All right, so we'll start. My name is Azza, and my background is actually, I do have some experience in histopathology. I've done an MD in Sudan, an MD pathology, and I majored in histopathology, and hopefully I will be following through here. So the objectives, as I just mentioned earlier, for this presentation would be to know what is histopathology, and just briefly. And then we'll just go over the program, the training program here in the UK. And then briefly, we'll also cover the application process. pathology, if we just think about it, I think everyone coming from med school, it's not a very well-known specialty. When we think about pathology, for me, I used to think about just the general, the acute inflammation and chronic inflammation, and that's it. I didn't know what pathologists did because we didn't have as much exposure to what pathologists do in real life. So it is basically the study of disease. So it links sciences, basic science, medical sciences and medicine. And I would like to think because of that, it's a very important specialty. It forms the basis of every aspect of patient care, starting from diagnostics, going through testing, treatment advice, and then the use of very cutting edge genetic technologies and preventing disease. That's pathology in general. Pathology encompasses more than 17 different specialties. As Reem was saying, tomorrow probably would be a pathology party where hematology is a pathology specialty, immunology, and histopathology, of course. We also have genetics. Everything you can think, a lot of things that you can think about are actually part of the pathology specialties. So for histo, we're just going to be talking about histopathology today. What it involves is that what we do is we examine, we see the tissue, the histology, we see what's causing disease in the tissues and cells also. So that's we do that microscopically and macroscopically, and we will then form a diagnosis for that patient. Okay, so a lot of people don't know exactly what pathologists do. So what will the working environment of a typical pathologist be like? So we do about 4 or 5 things typically, and I'll take you through them. The first thing is grossing. So that's when we receive the specimens from surgery, usually, or from or biopsies from medicine, ENT, all the specialties of medicine, and that's what makes it a very unique specialty, because you're dealing with with people from different areas of medicine. All specialties are involved in pathology. So you receive the specimens, and what we do is that we cut them up in a way. We examine them first, and then we cut them up so that it is possible for us to process them later on and have a slide that we can examine under the microscope. Okay, this step is very important. A lot actually hangs on it, and a lot of diagnosis actually could be made just from I'm not going to say just from looking at the specimen, but a lot of things actually it's heavily weighted in forming a diagnosis. Okay, we don't, after doing that, we document everything we do, and it's recorded, because later on it will be part of the patient's report. Okay, the processing of the slides, that part we do not do. We give it to someone else, usually a biomedical scientist or histopathology or a histology technician. They will deal with processing the specimens, and then they will bring us back a slide like this, very pretty pink slide. We use pink and purple a lot. So that's when we examine things under the microscope. And nowadays there's what's called digital pathology. And in digital pathology, what we do is we upload, these images could be uploaded, and we could see it actually just using our computer. So even the traditional picture of a pathologist sitting in front of the microscope could be changed now soon. A lot of people are using digital pathology all across the country. So we examine that, and then we form a report, and that's the pathological report that will have the diagnosis of the patient's condition. Pathologists also are involved in many MDTs across all specialties in medicine, as I said. So their opinion is weighed heavily in an MDT. We do a lot of research also and teaching, and there is it's a pitless it's a bottomless pit of possibilities for the research in pathology, actually. Okay, so now histopathology what encompasses also surgical pathology, autopsy, and cytopathology. The surgical pathology, which is basically what I said about the tissues, getting the tissues and looking at them under the microscope and arriving at a diagnosis. That's for living patients, okay? Autopsy is when there is a deceased person and then we have to examine them. It will be a macro examination and a micro examination. So we'll also examine their tissues and everything. And then we will probably do a report citing the cause of death and other things. So that's autopsy. And then cytopathology is the study of cells, diseased cells. So for example, a lot of us are, the most famous cytopathological test is the cervical smear. So in here, we don't take tissues, we deal with cells. We see what the cells look like and how we arrive at a particular diagnosis from examining. Okay. So now we'll just go over the training program here in the UK. This would be brief. So the requirements to enter a histopathology training program, of course, you need a medical degree, you need to be GMC registered, and you need to have done a UK Foundation training program or its equivalent. So for us, a CREST form would be more than enough. Okay, so to train to be a consultant histopathologist here will take about 5 years. And then the first 2 years, you will do histopathology, as I said, that encompasses, you'll be doing surgical pathology, cytopathology, and autopsy. So that's like you do the basics of histopathology in the first 2 years. And then you could go your different way by specializing. You either have the option of continuing in histopathology, or you could go into cytology, or you could go into pediatric and perinatal pathology, or forensic pathology, or neuropathology. So if you choose any of those, you spend the rest of the 3 years doing those, okay? If you choose to continue to train to be a histopathologist, once you're done, you could choose areas that you're interested in. So say, for example, if you're interested in GIT histopathology, and then you could do either a fellowship in it, or you could do a number of required cases that will register you in the specialty registered, so with a interest in. So you'll be a histopathologist with interest in GIT pathology. So that means that you are a GIT pathologist. Okay. The examinations, there are 3 examinations to be done during the training program. After the first year, people would, trainees would do a stage A exam, and that just that will just test their competencies. If they're not successful, they'll have to redo it. And if they can't pass it the second time, after a certain amount of trials, then they would have to stop the training. After that, you have to do your FRC path, histopathology. So your fellowship of the Royal College of Pathologists for histopathology part 1, and your exit exam would be part 2. Okay, so the application process, so recruitment is national through the ORIO. Also, competencies assessed in the application, experience and commitment to histopathology. Because I've heard from a lot of consultants, histopathology consultants here in the UK, that they would have a lot of trainees in, and they don't usually have the background of what is the specialty is about. That's why they have a high actually dropout rate. That's why they've been weighing more on the commitment to the specialty because of the higher dropout rate, because people aren't familiar with the specialty. So they feel that if you are more familiar with the specialty, and if you evidence that you have more commitment to the histopathology, you're less likely to drop out and you're more likely to continue and be successful. So they do appreciate some experience and showing. You don't need to just have the experience. It's just that the commitment could be just through going to a taster event for histopathology, or just spending a day or two in your histopathology department in the hospital, for example. Another thing is the clinical knowledge. There will be a certain questions, certain clinical scenarios that they will ask you about, the pathophysiology of certain diseases, mostly common diseases, like, for example, asthma or cardiac failure, stuff like that. They will also touch on autopsies. So basic clinical knowledge and also personal skills. They believe that a pathologist should have a certain set of skills, including they need to be good communicators, because mostly they'll be working within a team. So they need to be good communicators and have very good people skills, and be a team player. Also, a pathologist need to be able to have an eye for patterns, because that's what you will be doing. Basically, that's your life, that's your job. You need to see patterns in a picture. So they would be able to weigh that in a way or another through certain questions that are a part of the application and also the interview. Also, there's the self-assessment. I will just show you. The self-assessment has 11 points. So that's the, I think Islam covered it perfectly yesterday. So more or less, we're just going through this over and over again. So it's undergraduate degree, postgraduate degree, and qualifications, presentations and posters, and presentations, whether oral or poster presentation. Oral takes more points. Your publications, your teaching experience and training and teaching, quality improvement projects, your leadership and management, and then commitment to histopathology as a specialty. And well, yeah, that will be the conclusion of my presentation. If anyone has any questions, please.
Thank you. There are no questions in the chat box. في أي سؤال عنده أي سؤال من الparticipants?
I just wanted to ask you questions to ask.
Sure.
So, About FRCP path, or is it different from the histopathology FRCP, or are they the same? I'm always confused because there are many specialties that they do the same exam. For example, the hematology, the oncology.
Yeah.
And
So
then, yeah.
So the FRC path, it's the Fellowship of the Royal College of Pathologists. It's for all the 70. I think there were about 15 different specialties with different exams. So the FRC path for the histopathology, you'll have to do the FRC path histopathology. For hematology, there are two exams, one for doctors, which is FRC path hematology part for doctors, and then there is the FRC path hematology for clinical scientists. So yeah, each specialty in the Fellowship of the Royal College of Pathologists has a different exam, but I'm not aware of an FRCP. That is, I think that's for the Fellowship of the Royal College of Physicians, not FRC path, right, Islam?
Okay, that makes sense because obviously I don't have any idea about the FRC path for hematology and histopathology, but I think that's a good idea, isn't it?
Yeah.
It's good to know that at least I'm not taking the exam for everyone, you know?
Yeah. Yeah. FRCP is the fellowship for the physicians, but FRC path is for
And then, for example, FRC path histopathology is different from FRC path for hematology.
Yes, totally different. It's just that the Royal College is one because the specialties are so
got the same idea.
Varied, yeah. But the Royal College is one, but the exams are even for infectious, they have to do the microbiology one. The one that Marwa just it's also in FRC path, but it's for microbiology.
Okay, thank you.
You're
Yeah.
welcome.
Are there any more questions? So if there are no more questions, I will just say thank you to our presenters for today, and we will see you all tomorrow, inshallah.
Inshallah. Thank you.
Inshallah.
Thank you. Bye-bye.
See you tomorrow.
Bye.